This is a talk that I gave at Seattle Spine Foundation. It's a little bit of a compilation of some of what we've done in MIS deformity, and um, a bit more aptly at the mid section of the talk, we'll talk about the pitfalls. Sort of what to look out for, where some of the downsides of the things we've learned. Uh, so, these are the kinds of deformities that we'll see. Um, this is how we've historically managed it, and frankly, a lot of times we still have to do this. But a decade and a half, 2 decades ago, as we started to use MIS in degenerative, there was an appropriate questioning as to whether or not we could accomplish some of these goals in deformity surgery with MIS techniques. And there's a learning curve, of course, and what we could do at the beginning, what we understood at the beginning of applying some of these techniques has changed for different reasons, because we've got better at them, the technology's advanced, and with that, there have been changing and sometimes unforeseen risks that we have to reassess. And why even think about it? Well, as you've seen with our practices, deformity surgery is not a trivial risk. It comes with a high morbidity, high risk of complications and failures, and it's quite challenging on the elderly population. So there's a rationale to try to mitigate some of that risk by using different techniques, and that ultimately can defray some of the costs. We learned from degenerative spine that MIS had a role, perhaps, in reducing the overall cost of care, as Steve and Todd showed in their economics of MIS spine surgery paper last decade. So lots of work has been done. These are largely early efforts to evaluate, often in a retrospective, but sometimes in a prospective way, what we were doing with MIS techniques in the deformity population. The clinical outcomes early in the process of evaluating the techniques were not too shabby. As you see, though, the um, deformities were fairly mild, CAB of 42 in this series, but there was an improvement in SVA and a reasonable drop in the deformity. I'm sorry, in the outcome metrics and visual analog scales. So, what are the benefits of deformity correction with MIS? Well, you certainly have less EBL. You see that up on the top left. Less ICU requirements. Neil the street showed that he was doing a lot of these surgeries with no post-op ICU stays, and I think that's largely been the case with most of the studies, that there's a diminishment in the critical care nature of some of these surgeries, even with similar levels of deformity. Um, the home versus skilled nursing facility rehab placement, Mike Wang looked at. And granted, again, fairly small deformities, but fewer skilled nursing facility requirements. When we looked at a propensity matched group of open versus MIS surgeries for deformity, there were 280 patients that were evaluated, and they were baseline propensity match for deformity, or at least these aspects of deformity, the PIL mismatch, PT, and SVA. And all of the groups were reasonably improved from an outcome perspective, or a problem perspective, but the patients with MIS surgery had less EBL, as has been shown in other studies. And with the same deformities, very notably, there were fewer fusion levels utilized with MIS surgery. And I think that's an important thing to sort of take home from the talk, is if you have a deformity that can be managed open versus MIS of similar magnitude, and you can accomplish the goals, but do it with fewer levels utilizing an MIS approach, there may be an ultimate or net benefit. So that's certainly something to pay attention to. The lower major complications that you see here, is earlier in the follow-up period, but seem to suggest MIS may have a little edge. Complications, when you look at MIS versus open deformity surgery, and this is another paper looking at 20 patients in each propensity group or propensity match group. And there were lower intra-op complication rates that you see here, but the overall complication rates were not statistically different. Again, 20 patients in each group doesn't provide for a great statistical power, but nonetheless something to be scrutinizing in the future. Again, less blood loss, and notably the length of stay was equivalent. And that's something that we'll revisit in terms of a concept and where that is influenced and the meaningfulness of it. The open group had less OR time, a complication rate of 63%. So when you look at cost of care, the OR time is probably a relevant feature and not something to be dismissive of. If you're taking substantially more time doing MIS, we probably in the end will have to look at the net benefit in some question. Can MIS accomplish the same goals? Well, that's a great question that we've answered somewhat, but as I said before, the technology has evolved and we can do different things and more advanced corrections. This is a study that looked at more significant adult scoliosis deformities greater than 50 degrees and evaluated interbody fusion techniques and found that laterals tended to provide for less transfusion risk, had a better post-op COB improvement, and less EBL. So just a shout out to laterals, providing for some potential benefit and capacity to manage more significant coronal deformities. But limitations are definitely there. This is early in the MIS evolution. This was 85 patients looking at surgical techniques that extended from standalones. Interestingly, we did some of that early, not always as a purposeful maneuver, but sometimes because patients wouldn't let us continue. And then obviously a fair number of full MIS, circumferential MIS is what we call with screws in the back, and then hybrid where open technique was used in the back with hopefully a little less oomph in terms of osteotomies and releases required to get the job done. And when we looked at that group, what you could see was there was a ceiling effect in terms of the COB angles that were corrected for it. And as we got above 50 degrees, the hybrid techniques seemed to be more necessary, at least more utilized, I should say, to correct those deformities. And you can see the 20-30 to 34 to 55 sort of shed some light into the sort of limited capacity for MIS as it was applied in managing these coronal deformities. Greg looked at the sagittal plane specifically, and the more significantly deformed patients definitely struggled to achieve the improvements in PROMs and radiographic realignment. And this was, again, retrospective, arguably not necessarily acknowledging of some of the more advanced techniques like MIS PSOs, or potentially just sort of a recognition or adherence to the surgical goals that you could probably still accomplish if you were mindful of doing it in a way that was focused on the ultimate corrections in those parameters. So ACRs came about largely here with Beiruz and some others. Luis Pimenta helped facilitate that. And when we looked at it initially as a potential corrective maneuver, you can see here how it fared favorably in terms of its focal correction capacity relative to the PSO literature from Keith Bridwell and Frank Schwab and others. And in a head-to-head study, it seemed to show a demonstrably reasonable improvement in lumbar lordosis relative to PSOs. Pelvic tilt was actually a bit more favorably improved. And then when we looked at the radiographic corrections, they were relatively similar to PSO. EBL was 40% less, and the complication rate was approximately similar between the two, mostly on the backs of the posterior work. When you looked at those patients, they still required open posterior work for the most part, which probably drives a lot of the complication rate. The Virginia Mason group with Raj Sethi looked at a nice head-to-head match clinical comparison of 14 PSO and 13 lateral ACR sagittal plane deformity corrections. And you can see here a significant drop in EBL, and pseudoarthroses were less. Now, older techniques, I believe, with the PSO, not the full-right satellite rod type of constructs, but nonetheless, an interesting and well done head-to-head comparison that represented ACR as a very appropriate technique at the time. And here's a look at the use of an ACR, perhaps in a non-distributive fashion, but just a way to restore sagittal plane alignment in a patient with multiple issues, including pseudoarthrosis after multi-level fusion that was flattening at 4-5 and a pseudoarthrosis at 3-4. What about the more severe deformities? Well, look, there's obviously going to be some ceiling effect in what we do with MIS surgery, but there's probably a role for MIS in decreasing the need for PSOs, VCRs in some cases, and allows you to perhaps loosen the spine up and perform more significant corrections with less intensive posterior maneuvers or combination maneuvers. There are cases where MIS, such as an ACR, could fit well with a PSO in a more severe deformity where there is some capacity to utilize an open disc space. And it may have a role with osteopenia and providing some additional structural support. So there's fixed mobile deformity, and the rigidity matters. You can use dynamic radiographs to determine what to use, but lots of options for sagittal plane correction, mini open ALIF with hyperlordotic implants. Still a question as to whether MIS TLIF has a role, but if you do bilateral resections and add a PSO in a PCO in a less invasive fashion, perhaps there could be some role for that on a more limited corrective capacity basis. The laterals, ACRs, and PCOs and PSOs can be done less invasively with some challenge, but reasonably well. There is a transforaminal anterior release that was described by Sweet, one of Lanke's prior fellows. This is an open technique, but from a focal perspective, I suppose you could apply this and get some pretty substantial correction, as was described by some other authors. The MIS TLIF technique that was described in a similar fashion showed about 17-degree average segmental correction. So, this has to be reproduced in my mind in multiple studies, probably to be broadly adopted. But here's an example of doing an MIS PSO where you can do an open sort of skin incision, preserve the underlying muscle tissue using a paramedian approach, or the MIS PSO, as Mike Wang described, which you see here, and pretty impressive corrections utilizing sort of a focal open limited exposure where the PSO is completed and otherwise perk above and below that. And Greg's done some of these, I believe, with largely good results. So when you use MIS for adult spinal deformity, you have to anticipate the correction that typically is acquired by what are more often large interbody devices, whether it's laterals or ALIF. And that means that you have to plan ahead, understand the bony versus disc anatomy well, three-dimensionally. And additionally, the early learning, I think, from MIS was wrought with some challenges in the higher level deformities, and our failures were often, I think, a result of us focused on the technique rather than the goal. And so one of the things to be thoughtful about if you use MIS with deformity is you have to be prepared for intra-op adjustments in the plan. That may be on the anterior side, but it's definitely on the posterior side. If you are thinking, I just am going to do a perk fixation, um, you may be missing the target more often than you think. And so as you saw with that open midline skin incision, but then working below that in the fascia, that is an approach that gives you an adjustment capacity. If you can't get the correction you need, it's not catastrophic to try to adjust the plan and maneuver in a direction that may be a hybrid technique in the end to get your ultimate correction. Some of the pearls for laterals, we tend to like the concavity for approach. It limits the incision typically to one location, and you typically want to start top and work down to build the spine away from yourself. There are exceptions to that. If the L4-5 tilt is quite aggressive or falling off, sometimes doing that level first can bring the other cephalad aspect of the spine into better alignment towards the focality of your lateral incision, and then you go back to working from top down to the L4 level. The baseline sagittal and coronal alignment should be very scrutinized going into surgery, and beware of compensatory upper lumbar curves for what are lumbosacral fractional curves that are related to dysmorphic bony anatomy. That may be asymmetric trapezoidal L5s, asymmetric S1 or sacral promontories. You have to look at that. You can see it sometimes on coronal MRIs. I find the coronal recons of the CT to be the most helpful in really understanding this. And I find that the radiographs often are very difficult to really ascertain this in a resolute way. So look at those coronal recons best you can to anticipate those dysmorphic bodies. And this is an example here of a trapezoidal L5 vertebral body. Not totally sure, but maybe some asymmetry of the sacral promontory. But if you do laterals in a patient like this at L4-5 and above, you are likely to be staring at an unfortunate coronal malalignment that is global and difficult to really recover from. And in practice, it can look like this. This is a physician who had a relatively minor coronal deformity and primarily leg pain with some back pain. And laterals were performing. You see what happens when you perform laterals. Very powerful correction of the coronal deformity. But what you see with an untended to L5S1 level is a coronal global malalignment. And this was a staged procedure. So we got him standing to see what the outcome of the laterals was, and then went back with an ALF to correct the asymmetry at the disc space somewhat and get him better corrected. But as fancy as MIS surgery is, and particularly the laterals, and as powerful as they can be at coronal correction, they often can overcorrect. And these are things that we've learned along the way. This is a case from a decade ago. Prior to I would say our real, more astute understanding of distributional alignment. And granted, a rheumatoid patient with poor bone, but probably a bit overcorrected for her PI, which is quite low. And you can see what happens. And again, here's another patient with a relatively low relatively low PI or average PI, and a bit overcorrected in this case with laterals, as you see in the upper lumbar spine, that are probably a bit aggressive, that provide too much lordosis where you don't need it. So the Rousseli shapes and the LPA uh, normalization is something to really pay attention to when you do MIS, particularly in the mid and upper lumbar spine, so you don't overshoot your target. Take these Rousseli shapes to heart. If you're going to apply MIS, I would say it's one of the things that we're hopefully better at prescribing and a bit more accommodative of as we utilize MIS deformity surgery. So again, this is from Mike Kelly's talk. Um, Commit this to memory, put it in your data banks, and really use it aggressively as you plan for these deformity corrections, not just open, but with MIS in particular. And realize that when you use MIS, in which case most of the time you're starting in the front, you can absolutely hose yourself in the back. So it takes arguably a little more thoughtful planning and restraint in those areas that you might be prone to overcorrect because you can't recover well, and not nearly as well as you can open, where you can sort of unbend the rod or do some fancy footwork on the posterior side to correct for those overcorrections. Uh, there are algorithms here that you see. Believe it or not, we're working on a MISDEF3, but these are following this iterative improvement in technological advancements as well as our understanding, so that you can be a little more prescriptive in where you apply MIS deformity surgery in your practice. And customization of interbody implants will probably make this a little easier in the end. Things like laterals and A-lifts in particular that allow you to plan ahead and dial in the correction before you go to the back, rather than using stock implants or doing more guesswork with these difficult MIS deformities, are likely to make a difference. So who's a candidate for this sort of MIS technique? Well, generally the disc spaces have to be available for the most part, unless you're talking about MIS PSOs. And you want to be able to get there safely. So, if you've got anterior psoas muscles here at critical levels for correction, you need to be thinking about a different approach, most likely. Vascular anatomy is much more critical to scrutinize than when you're doing open deformity correction. And that includes the contralateral side, as you see here. The scoliosis deformities change the position of the nerves in the vessels, and so be aware of that. Be aware of how ventral you may have to come for certain deformities versus posterior, given the rotational anomalies that occur. And realize that you're going to unwind the spine. So here's an example of a rotational anomaly. Coming from this side may be quite difficult just because of the amount of rotation of that deformity versus coming through this side. We're running out of time, so I'm going to skip forward a little bit. So, when you contemplate doing MIS deformity surgery, particularly with laterals, you have to be at a level of efficiency with your laterals that is, it's going to vary by surgery, but you probably need 50 to 100 laterals under your belt before you have that technical acumen and efficiency to get through some of the challenges with it and be extremely comfortable with the anatomy and the approach, and then obviously with understanding deformity principles. ACR can be utilized. It's obviously used somewhat sparingly, mainly because of the distributional lordosis concerns that we've come to understand in the last 5 to 10 years. But certainly you have to do it when there's a focal deformity, typically above L5, and in our practice, it's historically been a bit more above L4, just because of the heightened risk at 4-5. It's going to be difficult to accomplish with prior posterior fusions or ankylosis. With scarring in the retroperitoneal space, it's a no-go. and you certainly don't want to do it where the vessels look adherent or compromised in the anterior spine where you have to create some room. This is a look at posterior docking. You have to get more posterior for the ACR, and then once the ALL is released, you will tend to have the implant migrate. So you really have to be fairly far back and really focus on the posterior height of the implant rather than the lordosis alone. You need to create space in the foramen and not have that clamp down on the backside. So being posterior and having 6 to 8 millimeters of posterior height will typically help with that, if not a bit more posterior height once you go to more lordosis. Let's skip forward a little bit here because this was less about an ACR technique than just the MIS. And that is it, guys. I think we'll have an ACR talk later in the season. But the real take homes that I wanted you to get from this talk are the capacity for MIS deformity being somewhat limited, and the more important nature to the planning and the inability to correct for overshooting with MIS once you bought the farm with the inner bodies. So pay attention to the bony anatomy, pay attention to the coronal alignment going in, and make sure you know where that's headed from a lumbosacral perspective before launching MIS techniques. Sorry for the short notice. And
well, thanks for filling in so quick, Bob. That was awesome.
Yeah, thanks, Bob. Yeah, we learned a lot with the MIS deformity, huh? And I one of the take homes that I get from this, as you pointed out, like we focused a lot on technique and not about the objectives. And I think that was the real hallmark when we started doing these. And then I think the other thing you pointed out in some of your pictures was that we really didn't understand how powerful these techniques were and how we really overcorrected a lot of people. You know, gosh, we've learned so much.
Mm-hmm.
Yeah, all that early data, it was always talking about how you couldn't create lordosis over and over and over and over again. It's every meeting was saying that. And I think it had this like negative thing in our brains. We all knew it could, but like it was almost like we needed to show the world that we could, and we just created a lot of it.
Yeah, we
way
did.
too much of it, and like it's interesting to see like all these naysayers, because all the published papers, every debate they would say, the lateral inner body would create, on average 4.5 degrees, a T lift -1 and an A lift 8. It's like the classic. Every paper came out of that, but the reality is they're all looking at the wrong thing, right? It really doesn't matter what the segmental lordosis is, as it does matter as it relates to its region and then its overall global alignment. So like we're just taking it out of context because you don't want 10 degrees of lordosis at L1-2, but we were getting it, down low. So we've definitely learned.
Yeah, what I hope is we don't throw it out. I mean, I don't think we totally understand its role yet, its place in what we do. I alluded to it early. There's probably a sweet spot for MIS to make surgery better, cheaper, more cost effective, but it has to be in the right place at the right time. And if all you do is MIS deformity correction, you're probably under treating or over treating in some cases and over resource utilizing in some cases. So I hope our research gets to the point where, as we understand the deformity principles, and that's a moving target, we as a deformity treating group get a little wiser about where we deploy it, and not stick to this sort of two camps. It's MIS or open. I think
Agreed.
there's a role for both.
And there may even be like, a lot more role for true hybrid surgery,
Mm-hmm.
So that's what we got to figure out.
Yeah. Any questions, fellows? That's good.
Yeah, no, it was good. Thank you. What's the biggest mistake you see people make when they're like misapplying the MIS approach? So like open deformity versus MIS, like when should you really go for the open versus trying to get away with the MIS? I know you talked a little bit about like lumbosacral anatomy. Is it just paying attention to the parameters and distribution and kind of the goals of surgery, or how do you avoid making that part?
Yeah, you just said it. I mean, I think it's people make the mistake with MIS, or at least I think they've made the mistake historically by making MIS the focus instead of the radiographic targets the focus. So, and you can get there a lot of times with MIS. It's just about how much work you want to put in, and so you have to plan and you have to have the right targets. If you do those two things, I think generally you're going to be able to get there with a lot of cases utilizing MIS in the mild to moderate realm. But people generally make the mistake by saying, I see a deformity, I want to use MIS, and they don't plan it and see that their target is reasonably going to be achieved in the coronal and sagittal plane by doing it. So that's a little bit of a feel thing. I mean, you gotta, if you're going to do, for instance, laterals, and then think you're going to get away with a TLIF at 5-1 in a patient who's got a real compromised 4-to-1 lordosis, you probably aren't going to get there, or you're going to struggle trying to use an MIS approach to the problem. Versus if you do an ALIF at 5-1 and laterals above, and then you can perk the back and keep an MIS approach alive and well, but still distributionally realign well in the sagittal plane, you're great. But by the same token, if that patient's got an asymmetric sacral promontory and you do that, you've just hosed him coronally. So again, it's all that sort of thinking ahead, planning ahead, both planes, right targets, and then try to do your best at extrapolating what your inner bodies are going to do in both planes and make sure you can get there.
Hey, Dr. Eastlack, thanks for the talk. It's Ryan. In what cases, it sounds like the ACR indications are becoming more and more limited. In what cases do you even do an ACR anymore? I haven't never seen one, so.
Gosh, they're in my mind, they're for focal deformities. I don't like them below 4. So, I mean, if I've got an open disc space and I need a greater sagittal correction, I'm going to do an ALIF at 4 or 5. I just think that's just less risk, and we've got good vascular approach surgeons to manage that. But above 4, if you have a focal deformity, say a disc space that's collapsed ventrally, but you can release it, and there's a lot of focal deformity at one of those levels between 1 and 4, I think it's reasonable. You just have to be careful as you get higher, because you don't want a hyper aggressive correction the higher you go. So let's say you have a collapsed disc space at 1-2, a bony erosion. So you've created a trapezoidal or wedge deformity of one of those vertebrae. Plus you've lost the disc space ventrally, and the combined wedging of that segment is 20 degrees. That's not an unreasonable place to think about an ACR to get a focal correction. Is it worth it doing that versus trying to just do a release in the back? That's a matter of scrutinizing that level. If you're trying to make up for bony loss, say you lost 15 degrees of bony alignment there from erosion and 5 degrees from the disc, an ACR can make sense there because you're replacing that bone. And it's that wedging effect with a structural support in the front and releasing the disc space and making the work in the back easier than perhaps a PSO, which you'd otherwise have to use. So think of it for more focal deformities where the disc space is viably opened, where you've lost some bony, you've gotten some bony wedging, like a compression fracture concept, but the times that I'll use are whether you get these erosions and you lose some of the bony anatomy in terms of sagittal segmental alignment. So that's why we use it less, and just like we've gone to PSOs at 4 and 5 a bit more often these days. I'd rather go to an ALIF in the front if the disc space is open between 4 and 1. Similar to if it's fused, I'd rather do a PSO at 4 or 5 to get distributional lordosis, pelvic tilt driven down, just more effective tool. So did that answer your question, Ryan? I think the reality is
Yes, it
we don't
did. Thanks.
have as many of those circumstances where an ACR fits well, or for that matter, where a PSO is appropriate above L3 anymore.
That's really nice context, for like historical context that I didn't really quite understand. That makes a lot more sense now. One question I had for all these MIS deformity cases, like how much are they in the past, like when you were doing these like laterals and then perk in the back, you know how you would typically kind of expose the facet and drill it out and lay some graft there. Was that being done? Because I saw a lot of revisions with Dr. Mundis where this technique, there's no fusion in the back at all. And you know, if you're doing your ACR, do you still release a little bit of the facet in the back to get your correction from the back, or were they really just purely perking with stabs?
I think it varied by surgeon. You know, early on, I think we were a little less aggressive about releasing in the back. But if you want to get more correction, you generally have to do a PCO in the back. And we did that as well to make sure you didn't get facet creep into the foramen. That's a combination of attending to the posterior height, so you have adequate posterior height. When you clamp down in the back with an ACR and the posterior aspect of end plates come together, the facets are also driving into the foramen. So if you haven't stayed posterior enough, or you don't have enough posterior height, you would get nerve root compromise as you went into more hyperlordotic state as you released the back. So for the most part, we started doing a lot more PCOs at the ACR site just to eliminate that issue and to get as much correction as the cage would allow for. So, you know, and that's very destabilizing. I'm not sure that's necessarily helpful to the fusion when you do it that way. But your point about, you know, whether you're getting fusions on the back is well taken. Does it help to fuse the back or to add graft? Probably. I mean, certainly historically when we were using peak cages with, you know, fusion rates that were in the 80s, probably made more sense and was more helpful as we've gotten more higher fusion rates in the inner bodies as of late. I don't know that it's quite as meaningful.
Yeah, there's also a paper we published looking at the MIS osteotomy classification. So it was kind of built off of Schwab's, but we added in the anterior column. So that's a good paper to reference to. I think Uribe may be the primary on that, and then but he and I put that together. So another good one to reference if you're looking at like sequentially releasing these patients and what you can achieve. But there's good basic science data from it, cadaveric studies as well as clinical now. So
what is
right.
MISDEF 3 going to add to it? Sorry to add another question, but
It's a good question.
I'm just looking forward to the sequel. So what do we?
don't get me started. I personally don't think it. Oh, yeah.
Yeah, sorry, I just turned myself off.
Yeah, go. You got it. So like, you know, I'd let Bob fill you in too, but like, in my opinion, that's a bunch of crap. Like, those algorithms are stupid. So,
All right.
that wouldn't put much credibility on it. Some good credible authors on there, but you know, sometimes you're on a paper because you're the naysayer. Sometimes you're on it because you're the one writing it. So I'm a naysayer. Like, it doesn't make sense to me. I don't like the way they put it together. Just another way to get a publication. So, you know, my opinion.
Right. Perfect.
It's a very surgeon dependent issue, right? Like Bob said, you're not doing a 4 or 5 ACR. Well, that algorithm may tell you to do one. Like, so it's like, well, then that's relevant because I don't do that. I would go down the other pathway, you know. So it's that kind of stuff. And then, you know, the way it's broken down, I just don't feel like is representative of someone that understands deformity and how to treat it. So cool. All right, guys, 7:15. Let's go to work.
Yeah. Full circle. Bye.